Morency, I'm Eric. Today I'm going to do some palpations in your neck, on your shoulder and arms, and your back, as well as your glute area and your legs, if that's all right.
Yep, that sounds good.
Okay. So I'm going to start at the base of the skull, and if I come just off the occiput right in the center, then I'll feel a space, and if I go just under that, then I can feel a bony projection, which would be the spinous process of C2. And this gives us a good reference for the rest of the cervical vertebrae, counting down, as well as if the patient were to have pain in shaking their head, this would be a place that we could feel for any potential injury or yeah. And then if I move laterally, then I can feel the articular pillars, and also if I push through the soft tissue here, the paraspinal muscles, I can feel all the way out to the facet joints here laterally, and the articular pillars are what allow for the paraspinal muscles to have attachments in the neck, and on the facet joints they feel a little bumpy here on the lateral side, and then if I move further down, if I use my palm, I can feel the most bony projection here at the base of the neck should be C7, and if I move up one, then I can test if that is C6 by having the patient flex their neck and extend. And if the bone there disappears with extension and pops out further with flexion, I know that I'm on C6 vertebrae, and C7 will be just underneath that. C7 is an attachment for the rhomboid minor muscle, and also gives us reference for the start of the thoracic vertebrae, T1, starting just underneath there. And if I slide my hand down the side of the neck as the neck begins to bend out towards the shoulder, and I push into this soft tissue, I should be able to feel a hard end feel, which would be the first rib. And first rib is an attachment for the anterior and middle scalene muscles, as well as the intercostal muscles. And following the clavicle out, I can feel a joint space here, which is the AC joint between the clavicle and the acromion process. This is where shoulder separation occurs as an injury, and also as how the upper extremity is able to transport force there we go, into the trunk. And then if I continue on to the acromion process and then drop off the acromion process, and this is the subacromial space where the supraspinatus tendon is, and also as a site, common site for shoulder impingement. Then coming onto the posterior side, I'm able to feel a bony projection that runs horizontally. This is the spine of the scapula, which is the dividing line between rhomboids minor and rhomboids major, which are on the medial border of the scapula. It's also one attachment site for the trapezius muscle. If I follow the medial border of the scapula down to the inferior angle of the scapula, this is attachment for the teres major muscle, and if I draw a line between the two inferior angles, this should be approximately where the T7 vertebrae will sit. Coming back to the lateral side, using my palm, I can feel for a bony projection on the side of the arm. This is the greater tubercle of the humerus, which is an attachment site for 3 of the 4 rotator cuff muscles. And also if I move medially, then I can feel the intertubercular groove where the long head of the biceps tendon will run through. Coming anteriorly, I'm able to feel here a finger-like projection, hard end feel, which is the coracoid process of the scapula, which is an attachment site for the short head of the biceps and the coracobrachialis muscle. And then let's just face up a little. Moving down the humerus, I can feel the bone flare out here, which will be my medial and lateral epicondyles. The medial epicondyle is attachment site for the wrist flexor muscles, as well as an easy location for going posterior to find the cubital tunnel where the ulnar nerve runs. On the lateral side, we have the lateral epicondyle, which attaches to which is attachment site for the wrist extensors, and also is able to guide us to the radial head. If we drop off the lateral epicondyle, then we're able to feel the radial head. The radial head is the annular ligament runs on top of the radial head, which secures it, and so this can be a site for dislocation in children before that annular ligament has time to fully develop. Following the radius down, if we have the patient extend and abduct the thumb, we create the anatomical snuff box. We drop off the radius into the snuff box, then we'll be right on top of the scaphoid bone, which is can be commonly broken if the individual falls onto their hand. It also is a place where we can feel the radial artery, radial pulse there. We come onto the ulnar side, following the ulna down, and we drop off the ulnar styloid process. We'll feel a joint space, and the next hard feel that we run into is the triquetral bone. From the triquetral bone, we can move more palmar and find the pisiform bone, and also find hook of the hamate more distally and medially. Then going to the knee, I can feel on either side of the patella and feel the patellar ligament, and feel this soft spot here just under the patella on either side of that ligament. If I run my hands up and down, I'm able to clearly feel a line, which this is the knee joint line. I can follow this out. On the medial side, I'll be able to feel the MCL. On the lateral side, I can feel the LCL. And along the joint line, this is where the medial and lateral menisci will be. Coming on the lateral side of the leg, if I feel with my palm just under the knee, on the lateral side, I can feel a bony projection here. This would be the fibular head. And this is attachment for the LCL and also for the biceps femoris muscle. Then if I follow the shaft of the tibia down towards the ankle, I'll be able to feel a space here, and then a hard end feel just past that. And this is the talus bone. The talus is involved in the ankle mortise, which primarily allows for dorsally and plantar flexion of the ankle. And also the tali accept 90% of body weight, and so if we have problems here, then patients would have difficulty walking. Coming on the medial side, using my palm, I can feel a bony projection here in this most outward projection. And this is the navicular tuberosity, which is an attachment site for the spring ligament, as well as the tibialis posterior. And on the lateral side, I can follow the fifth metatarsal back to this projection here, which is the base of the fifth metatarsal, and this is the attachment site for fibularis brevis and also abductor digiti minimi. Go ahead and lay down for me. On your back. Then you can just pull your shirt up a little bit. Okay. So if I follow the angles of the ribs here and then drop off, I should be able to, with firm palpation, feel a visceral end feel, and this should be where the liver is. This would be a site that we would want to feel in case there's any abnormalities that might indicate needing to send the patient to a different medical professional. I also can then come from the sides with using my palms and push into the soft tissue and feel for the iliac crests. Once I find those, I can follow them up to the most anterior portions here, which would be the ASIS. And this is attachment site for the sartorius muscle and the inguinal ligaments. Then I can have the patient cross their leg over their knee and adduct into my hand for resistance. I can then feel the adductor longus and brevis muscles here on the medial side, and I know that the sartorius comes from the ASIS down to the pes anserine, making this triangle here with the inguinal ligament as the top of the femoral triangle. And the femoral triangle gives us reference for finding the femoral pulse and femoral nerve. And then, can you lay on your side, please? In side lying position, I can then come to the top of the lateral side of the leg and feel for bony projection under my palm here, which is the greater trochanter of the femur, and this is a location for external rotators to attach, as well as pain can occur here if the trochanteric bursa is inflamed. And can you go prone? Can I lift your shirt up just a little bit? So if I come here on the sides and feel for the base of the rib cage and the 10th rib and drop off, I then can also feel the first floating rib, rib 11. And then if I drop further down and move slightly posterior, I should be able to feel the 12th rib. Once I find the 12th rib, I can follow that to where the T12 vertebrae would be, and it also serves as an attachment site for the quadratus lumborum muscle. Going lower, I can then find the iliac crest again, and move posterior this time and feel for bony projections, which would be the PSIS. This is attachment site for the sacroiliac ligament, and also gives reference for the approximation of the S2 vertebrae in the middle. Using that as a reference, we can move up to S1 and then move up one more, then we'll be on the L5 vertebrae, which is a common site for low back pain, and also would then give us reference for the rest of the lumbar vertebrae moving up. And going back to the PSIS, if we then move inferiorly and medially, we can feel the border of the sacrum. As we follow that down, we can then feel a sharp medial turn of the sacrum, which is the inferior lateral angle of the sacrum, and this is an attachment site for the posterior sacroiliac ligament as well as the sacrotuberous ligament. And then lastly, if we come inferiorly with the palm of our hand and move superiorly, pushing into the soft tissue, we can feel a bony projection here, which is the ischial tuberosity, which is attachment site for both the hamstring muscle groups as well as the adductor magnus. I think that's all of them.